all so much for being patient. We are experiencing a few technical difficulties, but we'll get through them. Thank you for joining us for our first event for Black History Month. Our committee has worked tirelessly to ensure that we're bringing you events that you will enjoy and that are informational. This year, the Black History Month theme is the Black family. So we're going to be talking about representation, identity, and diversity. And so I think you'll find throughout the month, each event, we were intentional about putting an emphasis on the Black family and the challenges the Black family is facing today. And tonight, in particular, we'll be talking about COVID-19 and its impact on the Black community. Before I go any further, I want to introduce my co-moderator for the evening, Dr. Stephen Davis, who is a professor of history here at Lone Star College-Kingwood. Dr. Davis, thank you so much for agreeing to do this with me. He's always so gracious whenever I call on him to help me with any type of activity. He is always willing to do that. So Dr. Davis, if you have any words right now, I'll yield to you, and then we'll go ahead and get started with our panelist introductions.
No, I'm just really looking forward to this, and yeah, so the sooner let's get into it, but it should be a really great program tonight. We couldn't have picked a more timely topic, that's for sure.
Awesome. Well, panelists, this is your opportunity to introduce yourselves, tell us a little bit about your career, your education, anything else that you might want to share. So Dr. Evans, will you start us off, please?
Okay, so good evening to everyone. And again, thank you, Christian, Dr. Davis, for inviting us to this forum. And I am just really excited to be here, and hopefully we'll be able to share some useful information. So just my background, I am an internal medicine physician by trade. I am from the great state of Mississippi. I went to a small school called Tougaloo College. And I went to medical school in California at Stanford and came back to Texas to do an internal medicine residency. I also completed an addiction medicine certification before residency was required. But I spent most of my time doing emergency medicine up until about 8 years ago. So now my focus is more of public healthcare disparity and behavioral epidemiology, because I think that the real reasons that we have all these issues with our healthcare and with making these transitions to a better life in terms of health, it has a lot to do with behavior and our perceptions of what we're receiving to work in our environment and our culture. So that's the focus now. I currently work with a company called Vale Health. As a telehealth organization that sponsors treatments for psychological and for medical. So it's a startup company. We do events, and we're working with religious institutions and small groups to make sure that they're ready for this COVID season, and they're on. And then lastly, I work at Wheeler Avenue Baptist Church as the first aid care team director, where we take care of people that may have incidents at church. We also give guidance to medical issues that may arise, and health fairs and other issues that will affect the congregation. So that's kind of what I do in a nutshell. And again, thank you for inviting me.
Ms. Fleming, would you like to go next?
Absolutely. Thank you, Christian and Dr. Davis, for inviting me to participate. And hello to my fellow church member, Dr. Evans, who I'm also a member of Wheeler Avenue Baptist Church. I am a master's prepared registered nurse. I currently work for the Memorial Hermann Healthcare System. I got my start in nursing back in 1981. I graduated from Kent State University in Kent, Ohio. I am a diehard Ohio State fan and all things that have to do with Ohio State. I moved to Texas in the late 80s and received my master's degree in nursing from Texas Women's University. and I've held various positions within Memorial Hermann during my career, primarily in leadership in the past 25, 30 years. But I've been a nursing director, I've worked in case management, I've worked in managed care, so my career pretty much runs the gambit. I am currently a system director managing our patient transfer center, which involves facilitation of about 5,000 transfer requests a month into one of our 13 Memorial Hermann hospitals. So I do that in conjunction with our Lifelike program and have a team that really works that if you're out in the community and you need to move into a quaternary or tertiary care facility, that's what we do for you. And so I am very interested in this topic. As a matter of fact, one of the reasons I was a few minutes detained is because I got a call from one of my colleagues that we had 10 remaining doses at the Smart Financial Center, and could I find 10 people who would be willing to come and receive their first dose of vaccine. And so I'm trying to get dressed and call people and get names and date of birth so they can hurry over to the financial center, because as we will discuss later, I'm sure, the shelf life of the vaccine is important enough that we don't want to waste any. And so I actually found 10 individuals to get over there. They were excited. They're over 18 and they're excited to get their vaccine. So that's kind of my story. Thank you.
Dr. Williams.
Hello, everyone. Thank you, Kristen. Thank you, Dr. Davis. Hello to my other panelists for having me. My name is Dr. Ramey Williams. I am an occupational therapist. I am from Pensacola, Florida, but I have been in Houston for 9 years. I too am a Wheelerite, if that is a word. And I currently work for Department of Veteran Affairs as an occupational therapist. I've been with them for 8 years, but I've been a therapist for over 12 years. And I had my studies done undergraduate at Florida A&M University for OT. And then later on, the University of St. Augustine for healthcare professionals for my doctoral in occupational therapy. And that emphasis was on reducing hospital readmission amongst veterans and the role that occupational therapy plays within it. So this topic is very near and dear to my heart, and I look forward to speaking with each and every one of y'all tonight.
Thank you to all panelists. I'm super excited. I think that this is a very experienced panel. I think you all are going to give us more insight. And each of you have hit on subjects that Dr. Davis and I have spoken about. So why don't we just go ahead and jump in. We've been in a pandemic for almost a year now. So I think to start off, I want to ask you all, like, what did you all initially think about all of this? When we found out that coronavirus was now in the United States, what were your initial thoughts? Did you think we were going to be where we're at today? And anyone can go, just feel free to jump in.
Well, I'll say a few words about the expectation. So, you know, I thought that after we heard about how aggressive the virus was in China and how devastating it was when it first hit the West Coast and then eventually New York, I thought this was going to be something that we could have control over within a year. That was my actual thinking, that after 12 months that we would have control of the situation. Mainly because I thought we wouldn't have these surges that we saw in November and in December, and each time there was a major holiday and an event. So, but those kind of things, they surprised me a bit. So I knew it would take longer than what we saw with normal flu-like viruses. I just didn't anticipate it would be a 2-year recovery. or 2-year time period to resolve this issue.
My first experience after we were hearing about it, I have an employee who has family members that live in Taiwan, and she said to me, Cheryl, the US needs to get ready. There's a very bad respiratory disease in China. And I said, what do you mean by that? She said, all of my relatives are buying masks and disinfectants. And I said, well, but we had SARS and some other respiratory things that came up there. Are you sure? And she's like, they're taking this very serious. She says, and I don't think we're taking it that serious here in the US. So she would tell me stories about our family in Taiwan was on lockdown. They were already wearing masks. They were doing things because they've had experiences with these various respiratory viruses from China. And as we watched it unfold, I'll be honest with you, I thought, well, we would get through the summer. As Dr. Evans said, it just one surge after another. And as we're now into our fourth or fifth surge, and I'm in a meeting today and our numbers are at 800 plus in our system, I'm concerned about, is this going to be for the next 3 or 4 months with numbers at that rate? Because it seems like every time we have a celebration of some sort or a holiday that we have this rise in COVID cases. So definitely didn't think we would be where we are today with this. I actually thought we'd be under better control, if you will, at this point.
Okay, so for me, when I first heard about coronavirus, I heard of a pandemic. Now, I'll be honest, I have heard of an epidemic before, but when they said a pandemic, it kind of took me back for a minute. So it was like, okay, how is this different? What are the factors? Like, what is this going to look like moving forward? And how does it affect my current work area and work life right now? Because at the VA, it's an open door policy. So at that point, we are seeing veterans on site. There's no appointments that are necessarily that need to be made. It's a swing door policy. And so everything being kind of not really a mystery per se, it was more like, how does this currently affect my current family members? And how does this currently affect my work life? And just to see the transition between the initial report of it to where we are now has just been completely unbelievable. And like Dr. Fleming said, I thought we would totally be farther down the road by now than where we are right now. So it has been an adjustment.
Well, let me jump in right there and get to the crux of a huge question all this raises. Is there any doubt at all, based upon the data, that a disproportionate number of Black people have suffered in terms of the number of cases and deaths? And if that is the case, how do you explain it?
So how much time do you have? All right. So I sum this up as pre-existing conditions. So these are pre-existing conditions, and what we normally think about when we think about pre-existing conditions, we're talking about diabetes, high blood pressure, obesity, renal disease, lung disease, but that's only part of the issue. The true pre-existing condition is the social economic status that has been ignored and has never been addressed, has never been truly addressed. And because of that, we have the pre-existing medical conditions that we always talk about. But the true pre-existing condition is the social economic status of minorities, Black and brown.
Well, does anyone want to follow up? I guess what I can follow up on, and anybody can jump in here, is there any doubt that, Dr. Evans, what you're referencing is systemic racism? And if that's true, how does it make you feel when you hear people say, no, there is no systemic racism in the United States? We've had a number of especially prominent politicians who have spoken along those lines. Thoughts on that, please?
It's tough for me, and I won't even say tough. It makes me downright angry when I hear individuals try to tell me there's no systemic racism when, as Dr. Evans just mentioned, when you look at the socioeconomics in relationship to this virus and the number of Black and brown people that are dying from it disproportionately than any other group, and housing, income, education levels, access to health care, all of these are the result of a lack of. So why is it that those that have aren't suffering from this virus and this disease as those that are Black and brown? And unfortunately, we have systems in place that have been designed or set up such that Black and brown people just don't have the same access. They don't. When I look just at this city alone, to give you an example of access, we have 2 county facilities to take care of a city that has 5 million people, Bentob and LBJ. And who goes primarily to Bentob and LBJ for their care? Black and brown people. You may, unless you have an emergent condition, you may wait months to get an appointment there. That's the system we have in place for people. And you tell me systematic racism doesn't exist in healthcare?
And just to piggyback on the availability of healthcare. So we already know that healthcare is skewed to those who have income, those who have positions, and those who have education. As a matter of fact, if you are educated and have a lower income or a lower social amount of clout, if you're highly educated, your incidence of disease is less than those who are less educated. And it doesn't really matter about your income as much. So education will propel you past a lot of the inequities that we see. And you know that the pay for an African American with a bachelor's degree is less than the high school graduate of the main population. That's the bottom line. So, but the education still makes a difference because you know better how to better take care of yourself. Now here's the diagery. Here's the story within the story. And this diagery that we see right here in Harris County, we have the greatest housing boom on record in Harris County. We also have the greatest eviction record in the history of Harris County that's been stayed by federal intervention. And the fact that it's been stayed by federal intervention is the only reason we don't see the complete discombobulation of the lower third of our social and economic status. So how can a person who has to make a decision, am I going to pay for my rent and not have money to buy the supplies that I need to keep myself safe Or should I forego my rent, get kicked out on the streets, and use my monies to buy supplies that's going to not keep me safe on the street? So this kind of dichotomy in our country is the effect of what our government has done over the years, redlining certain housing areas so that you cannot get proper funding for your houses, giving suburban houses, suburban locations, more than enough capital access for their moves. Those are federal guidelines that have not been addressed. So that's systemic racism. You can't get insurance at a proper fair rate because you live in a certain district. Our whole county system dictates how well you will live in this country. County by county, zip code by zip code, dictates and predicts your outcome because those areas continue to be neglected. And we don't get Amazon building places of employment to employ those in those neighborhoods. We spend billions of dollars as African Americans on Apple products, but Apple will not hire you to work in their system. They just lost a lawsuit. Actually, just gave in to the lawsuit for publicity's sake and to be done with it, and paid a paltry $200 million to settle a lawsuit, but didn't hire any more people, but we spend our money on those products. So those kinds of things says that it's systemic, even with the big companies. It's the same, it hasn't changed.
Let me ask one more related thing, and then Kristen, after that, if you'll jump in and ask the next one, because we touched on data, and there are people, a lot of people out there who are questioning the numbers. And I wonder if for all of you, maybe we start with Dr. Williams on this. Do you think the numbers of the cases and deaths is being overstated in this country, or is it understated? What are your thoughts on that matter?
Okay, yeah. So according to the CDC, the information and the records that are being provided, I believe that they are accurate to the best of our ability. But I also believe that they're underrepresented of the amount of people who are dying from COVID and did not get tested, who did not receive treatment, or who are not a part of the actual statistics that are being presented. So although there are numbers that are present, I do feel like it's not a complete representation of everyone that's being affected by the actual virus.
And there's some word out there, I get it from students. They're hearing it from various online sources. Well, the hospitals are just reporting these deaths in order to get more money. Can you speak to that, please? Because that out there is in circulation.
Yes, sir. So with the guidelines, with the Veterans Affairs, the way they are recording everything, it's not based on financial dollar to receive more vaccines, because right now, if a veteran is over 65 or want access to a vaccine, they have it available. So it's not our guiding marker to determine who receives it. But when it comes to Black and brown community, there's a disparity on who receives the vaccine, who has access to the vaccine, how they have availability to it. And it's not based on the numbers, it's based on where they're located, where the amount of numbers of Black and brown in the community on who actually has access to actually receiving the vaccine.
So just go ahead.
No, go ahead, please.
No, just real quickly to piggyback on Dr. Williams's statement. So the reporting for diseases, it follows a real strict criteria. And if you really delve into how COVID cases are reported, they're still reported in the flu infectious disease category. And if you look at death rates, they're still reported primarily according to the #1 cause of their death, and that is pneumonias. So it may seem like they're just piling on, but they're still following the same protocols that we follow when we have 100,000 people die of the flu in 1 year, in a tough flu year. So those same protocols are being followed. Now, what I did learn from listening to the new COVID task, I'm drawing a blank on her name, just appointed by President Biden, to look at healthcare disparities in COVID cases, is that she states that minority cases are being underreported to such a great extent that it's too early to say what the true level is. That was her take on the current data.
I think the other piece of it is Dr. Evans mentioned about reporting about pneumonia, but there are a number of persons that now have had COVID and then may potentially die of complications post-COVID, strokes, pulmonary embolus. There's some other diseases that we're seeing deaths related from COVID that occur post-hospitalization. They come back with these issues that have occurred since they were initially diagnosed and even been discharged. And so I'm not sure those persons are getting captured in the number, because who's to say if that wasn't related to COVID as well? I mean, we're seeing more strokes in people under 50 than I have ever seen working in this capacity. The request to transfer 30-year-olds, 40-year-olds. Well, there's an increased clotting that's been seen in some folks with COVID. And so, so there's so many things that link to it. And, Dr. Evans is our physician expert, but I can tell you, there are just a number of different strange patterns happening with diseases that have some correlation to COVID, from diabetes to blood clotting to a number of things. So that my question is, and my thought is, so are we even reporting everything? Are we just underreporting? Somebody had a comment in the chat. Do you guys see that? That most people have no idea what it's like to have health insurance through an employer. This is not an issue to so many white Americans. Someone named Sandy that made a really good point. Another example of the disparities in our country when it comes to healthcare.
So as someone just sent a private message to me, and I think this is a good transition to talk about the vaccine. Her comment was, I'm an African-American female and I am skeptical of the vaccine because I am unsure of the testing period. Is it long enough? Should we trust it? Ms. Fleming, you've done a lot of work with the vaccination in terms of, seeing the distribution sites, and we've kind of had conversations about why people are hesitant, why is it more readily available with some organizations, but with other organizations there's more strict protocols and qualifications. Can you speak more about that, and why even within counties we're seeing some difference in terms of access to the vaccination?
So, this is one of those things to me. It's like there really is no perfect plan for this, because this is the first time we've had to figure out how to mass vaccinate millions of people. The government decided to categorize who should receive vaccine first, from the nursing homes and direct health caregivers, and then they added on the category 1B, with individuals that are over 18 that have heart conditions, diabetes, sickle cell, and a few other things that they've listed there as they're eligible. But then when it comes down to the distribution, not everybody can distribute vaccine. There's some storage requirements. We've heard the stories about Moderna and Pfizer. You know, Pfizer pretty much needs to be stored at subarctic temperatures, which most healthcare organizations cannot do. That's why you typically find that given in the hospital type settings, because they have the ability to store it. Moderna is often given outside of hospital settings because they don't have the same storage requirements. Then you have to deal with who has the manpower to be able to administer vaccine. Because I can tell you, you guys have seen the massive vaccinations that Memorial Hermann has taken on, but we're trying to fight the surge and give vaccine, you know, with some of the same healthcare providers that are doing both. And so those are just some of the different things that happen. And then the governor decided which areas would have hubs, right? Vaccination hubs based on a demonstrated ability to be able to vaccinate people in mass numbers over a given time period. And you have to be able to prove that your allocation that you're sent on a weekly basis now, you can get that out to the masses, all right, in order to be a hub. So that's why some places have received more vaccine. At one point, they were asking healthcare providers to send, this is to the government, you know, a list of how much vaccine do you think you're going to need this week? And then they would send you that particular allocation. So if you remember at the beginning, Memorial Hermann got probably the largest percentage, but we have the largest number of employees, all right, at that point, 16,000. Smaller places, the Kelsey-Sebo, CVS's, HEBs, they've gotten smaller allotments. And they're going to start ramping it up, because one of the things we found and we're working on within our organization is how do we help those that don't have these smartphones, that don't have the internet, that, you know, you cannot expect, like my mom, 85-year-old mom, she knows how to manage her email, but she's not going to go in and do a verification form, wait on an email to come, and then register for a test. I did that for her. We're going to have to take vaccine to the communities where people can either hop on the bus, come to a mobile unit. We've got to bring, this is my opinion, nobody else has said this, but vaccine to the people and have an easier way of giving it versus all of this sign up through technology means that not everybody has access to. Most of you are too young to remember, but some of you may remember, those of us who are older, the gas, shortage of gas in the 70s. So for you young people, let me tell you what they did when there was a shortage of gas in the 70s. There was a point where on some days, depending on your license number, odd or even, all right, the last digit, odd or even, you got to go and get gas on the odd day if you had an odd number, on the even day if you had an even number. Maybe we should get to doing something like that in communities. We're going to do everybody in zip code 77021 this day, and with something, you know, set up somewhere to be able to get that done. But we're looking at in our organization how else we can get it out to the community when it comes to distribution. One other point I might want to make, you did ask about how else are people having access. And again, the disparities, you know, most of the organizations have provided appointments for their patients, their standing patients. And so those patients that have been seen in the past 2 years that are 65 plus and or 1B have been receiving invitations. And so if you don't have a primary care provider that you've seen in the past 2 years, as a number of those in our communities who have not, they wouldn't have received an invitation. And so that's another reason some of the disparities are occurring. Okay.
You know, I disagree with the way the rollout is taking place. I disagree with the lack of a structured plan by our federal government in getting this thing out to us. It seems haphazard and a hodgepodge, to my estimation. You know, I look at what just transpired in the year 2020, where in a 6-month period, approximately, every single household in this country was counted. That means every nursing home was touched, every personal care home was touched, every household had the opportunity to participate. So I agree that we have to take the vaccine to the people in some form and some manner. But we have the data from the U.S. Department of Commerce on where these things should go and how they should be distributed. I'm just amazed that those things aren't being utilized and looked at as we prepare for to vaccinate the country. Cheryl, you're probably too young to remember. You probably too young to have had this, but I remember when we did a mass vaccination project in our school system, where we lined up for 3 days, and every student in the school system got vaccinated. That's actually was over a week's period of time. Got vaccinated during that week. So we've had opportunities, if we look at our history, to do mass rollouts, but I don't think that's part of the way the politics works today.
Yeah, I agree with you from the standpoint of I really wish they would kind of release it to the science groups to figure out how do we best, do this. When I say the science groups, I'm talking about the hospitals, healthcare personnel, what can we do? Because Dr. Evans, I think you're talking about when we lined up to get the sugar cube for the polio vaccine. And that's what we did as school-age kids. There was the vaccine for polio. It was a little square sugar cube. So you young people, imagine the sugar cube that you see that you drop into a cup of coffee. It contained a drop of the polio vaccine. And we did. We lined up like good little children and received our polio vaccine. But there have been some things that have happened in history in this country, and we would be remiss if we didn't touch on Tuskegee. We might even talk a little bit about Guatemala, because the same person who was associated with Tuskegee has something to do with Guatemala. People are leery of, is this something that, like somebody said, you've developed too soon? I'm a little leery of taking this because, warp speed, that's all we heard. We're going to have this warp speed vaccine. It made me leery, okay, as a nurse. And so what I did, though, I went to the science so I could learn about how does mRNA work, all right? Because this vaccine is different than what we're accustomed to having. I look at it, for me, the simple way for me to look at this is dead virus or germs, if you will, or weakened virus or germs, if you will, like the flu or smallpox, some of those things that we know of. And you were given that to help trigger your immune system, all right, to develop antibodies so that if you got the disease, you would fight it, right? Okay. So here we come now with this mRNA, which, stimulates the immune system to produce antibodies, but it's basically something they produced in this lab. it wasn't, I wouldn't say it was rapid. I would say they have been trying to perfect this mRNA advanced vaccines for a little while with some other diseases that were out there. So they didn't just start looking at this in 2020 as to how mRNA works. Okay, so I think that's one thing that the messaging needs to get out there, is that this didn't start because someone in the government said we're going warp speed and everybody started working on mRNA. That it didn't happen that way. It started long before the government ever got involved in this process. So one of the things I try to tell people, encourage you to learn the science versus what people are telling you. I listen to a podcast weekly for JAMA, which is a Journal of American Medical Association. It is given in a context in which most lay people you'll be able to understand. There's a lot of different conversations and topics they talk about, but you can hear some of the scientists versus always what you hear on the news. And I'll let somebody else speak, because I just want to talk a little bit about, how, the reactions to the vaccine and some of those things and that, but I'll let somebody else talk a little bit.
Yes, I will jump in just quickly. I think one of the reservations to receiving the vaccine is that a lot of people were thinking that it's a live vaccine. So they're thinking that you would be injected with COVID in order to develop the antibodies for it. And then that in turn will create the antibodies that you need so that you don't contract it. And I think it's a misconception because it's not a live vaccine. And like you said, Ms. Fleming, if they read upon the science of how the vaccine has been created, it can create ease on how the antibodies are being produced in our body. So I have had my second dose per se. And so far, I have not had many side effects outside of what has already been recommended, which was a sore arm, minor muscle aches. Other than that, I was okay. I didn't have any adverse reactions to actually having my first or my second dose. So I can actually say how I've been feeling thus far, and I'm about 2 weeks in on my second dose. So I agree with learning the research on how the actual vaccine was created.
Yeah, and to just continue in that vein about the vaccine and the trust issue, historically, Tuskegee, the syphilis case experiment has created, well, I wouldn't say it's created, but it added to this cloud of concern and hesitancy on African Americans about even just participating, not only in vaccine programs, but just medicine in general.
Right.
And if you look historically on how African Americans were treated during slavery, post-Civil War, during Reconstructions, did you know that for most of our medical journals, when we displayed our surgical evaluations, that only African American bodies were displayed on a number of magazines, not any other race or color? So when you wanted to show a grotesque or disfigured type of disease or abnormality, it would always be that of an African American or Black person. The father of gynecology would experiment on African American women and then perfect his techniques on those women. And then once he's perfected it without anesthesia, and then or chloroform at the time, he would then use his skillfulness to serve the majority population. So historically, these things have always happened. And so it's not new. And even most recently, we've heard of gynecologists in the in the Rio Grande who were doing experiments on women that were locked up in immigration status. So it hasn't stopped. But that being said, like you said, Ms. Fleming, we need a reliable source that we can go to that's going to give us guidance and truth about what's happening. So Tuskegee, from 1932 to 1972,
That's right.
and in 1968, there was a guy named Peter Buxton who was working his way through college by being a screener for venereal diseases, thought that this was a tragedy and an atrocity. He brought it up to our own United States government that sponsored it. They dismissed him. He went to law school. He sent notices back for a 6-year period that he thought that this was not the proper thing to do. They still wouldn't listen. So he gave the report to a friend of his that was a journalist for the Associated Press. And that's got the ball rolling to look at this from an ethical standpoint. So, so there's some justification for the hesitancy, but there's no justification for you not being aggressive about your health care and making sure that you get a reliable source that you can depend on to guide you through this scenario. Your physician, your primary care provider, a loved one who knows, JAMA, as Ms. Fleming has mentioned to us. So get a reliable resource so that you can navigate through the system.
Okay. Dr. Evans, wait a minute. Listen, I'm going to ask you, talk about Tuskegee, because there is so much misinformation, unfortunately, within our own community about Tuskegee, where there's this perception that they were given syphilis.
Oh, okay.
And I ask you because you're the physician on the panel, and so Kristen, Dr. Davis, forgive me, but I just think that should be cleared up, because a number of our people think that they were given syphilis.
Okay, so back in the 30s when syphilis was rampant, it was not only in the African American community, it was throughout the United States. About 30% of the people in this country came in contact with someone who had syphilis. That's a lot of people. So there was no cure for syphilis at the time. There was a treatment called bismuth and some mercury. That's it. It cured less than 30% of the people. So some physicians decided, and they went to the United States Public Health Service to get a grant to look at the natural progression of syphilis. So they took African-American men from Macon County, Alabama, which is where Tuskegee is the county seat, and where Tuskegee Institute is, Tuskegee College University, and they took initially 399 men, and these men already had syphilis. They already had syphilis. Nothing was given to them. They already had it. And during their experiment, at about the 3rd or 4th year, some of the scientists decided, well, we need a control. We need some people that don't have syphilis so that we can measure them against the ones that do to get an idea of their progression of disease. And you know that neurosyphilis is real prominent in the late stages, where you get difficulty walking, difficulty moving, you get heart disease, you get aneurysms, and and you die earlier than you would if you didn't have the disease. So they needed a control. So they added people to the control, but they never gave anyone syphilis. The ones who were in the control group never got syphilis. The ones who were in the original group did get syphilis. Now, there's a misconception that they all got syphilis also from interactions. A third of those men got syphilis from birth. So during the birthing process, because syphilis can be transmitted during birth, they got it during that period. Now, one of the reasons that there was a real fight not to shut this down. That's why those letters were being ignored from Peter Buxton, because at that time, the U.S. started profiting off of the technology that was being learned from those patients. So periodically, patients would be brought in for testing, and the testing would be a spinal tap, taking brain spinal fluid from the back, and a blood draw to see how much of the syphilis was in the bloodstream. And from those draws, they were able to develop some of the current type tests that we use to test for syphilis. Once they perfected it, they started selling, the US government started selling these products throughout the world. So there was a direct profit from the care of these patients. In addition, there was a nurse, I'm trying to blank on her name. She was hired, she was one of the 4 infectious disease, communicable disease nurses in the state of Alabama. They took her from a night shift, brought her down to Macon, gave her a nice car, gave her all the toys, all the trinkets, some dollars, so that she would engage the men to make sure they met and stayed in the study. They could not get out. In 1940, when penicillin was developed, and then in 47, when it was declared the treatment of choice, these men weren't offered the treatment. They were never consented to do the study. They told them from the beginning, you'll be receiving treatment. They never received treatment. And therefore, great atrocity for treatment, great atrocity for taking what was rightfully a person's right to be treated, and then taking their blood and sampling, making a profit off of it. And in the end, they received $30,000 if they had syphilis for 40 years of neglect.
Wow. I'm so glad you spoke at length about that, Dr. Evans. Her name was Nurse Evans. I'll never forget it. When I was at the University of Houston, a historian named James Jones published in the early 80s a book called Bad Blood. I wanted to get that out there because I recommend that to all the students. And Nurse Rivers is a really tragic figure. She was Black herself, and she was doing the job, following the orders of the doctors to sustain the experiment and what have you. And Dr. Fleming, I'd like to say you made a passing reference to Guatemala, and I don't know what you were referring to. Can you just at least briefly say a little bit about what you were referring to in that case?
So the thing that's interesting about, and I'm trying to remember when it was, maybe Dr. Evans, I'm not sure if he 40s, 50s maybe, when this same researcher who was involved in Tuskegee gave syphilis to some Guatemalan prisoners. And it was found out during, I think it was during President Obama's administration, when he issued the apology to the Guatemalan prisoners for what our public health service did. But it came out at that time that the same researcher, I believe it's a Dr. Archer, who was involved in Tuskegee, was also who was involved in the syphilis back during that time frame.
And I guess I'll just ask one real quick follow to all of you. We read about Tuskegee in the paper, and we know about the books and the like. Do you hear mention of it in the Black community? Is it a knowledge that's pretty pervasive out there, or is it something that just medical professionals are most likely to know about?
I hear about it. I mean, I hear people I don't want to be Tuskegee. How do I know we're not Tuskegee? And especially from older. And when I say older, people 60 plus that know that history. All right. Probably more so than our younger members who don't know that history as well. But I do hear that. I've had friends, to give you an example, who and these are educated people. When I say educated, they're college graduates who refuse, for example, to go to MD Anderson because they're afraid that they're going to use them as a guinea pig. All right. There's some real mistrust in our community about research and what happens to us when that occurs. I mean, I've heard it from friends of my own. And so, again, one of the things I try to do is dispel the myths and the untruths, because now we do have in our we have guidelines from the government that when you do research, what has to be disclosed and what information can be, captured and those things. I think it's a little, I wouldn't say a little, I think it's a lot tighter controls on it today than it was back then. But I think that it still bears watching, as Dr. Evans said. I mean, just by the example we had in the Valley recently.
Right. Yeah. So if you decide to get involved in an experiment, it's okay if you ask for their institutional review board members, right? Because every experiment that involves a human in this country has to have an RRB. So if you decide that you're going to participate in any study, then make sure you ask for that panel so you'll know who they are. But on the other hand, we can't neglect our own health care to the point that we're not going to get treated because we're misinformed or uninformed. And that's why it's real important to establish ties and relationships with reliable resources and reliable people that will help guide you through this process.
Thank you, Dr. Evans, for adding that. While we're still talking about the distrust with the Black community and with healthcare, what if someone is at a hospital system, and I've personally experienced it myself, a person of color, a Black person in particular, is having issues or challenges with getting the healthcare that they need and the attention they need at that time? How, some people, even educated and all, we know with maternal health, Black women die 4 times, at a higher rate than white women. So what would be your advice, to the Black community when we go visit those hospital systems and we know we're not getting the adequate healthcare attention? What are some avenues? What would you do in that situation?
Most hospitals, I will say, have patient advocates. All right. Most have patient advocates. And again, I can only speak to what happens within Memorial Hermann. If you have an issue or concern, you may ask to speak to the patient advocate or the charge nurse, or I would highly recommend that people escalate their concerns until you find someone that is willing to do something about the concern that you have. I do think that we have to not shy away from expressing our displeasure with something. And we just need to do it in a manner in which we can communicate our displeasure in an appropriate manner, but get our point across until we get results. I think oftentimes, I've had friends that have said, I came in and I had this chest pain, and they wanted to dismiss it as it was indigestion. And I've had indigestion. I know it's not indigestion. And they just had to push on that emergency room doctor to the point they asked, well, you know what? I need to see somebody else because I don't believe this is what is going on. And you have the right to do that. I just think that, and it's hard because you have this healthcare provider and you don't really want to rock the boat because I'm sick. I want to make sure people take care of me appropriately. But I think that everything can be escalated within reason.
I love the fact that you said escalated. And if you're not getting the results that you want from the person taking care of you, ask that someone else come to take care of you. Right. You have that right. Most of us don't know that the systematic way to escalate is that, you ask the charge nurse, you ask for the patient advocate, during the day, you ask for the social worker, whomever it is in the system that's going to be able to help you navigate your cause. And if that doesn't work, then you move up the ladder and ask for someone in administration. So it's good to have a plan. I'm speaking from a some personal emergency room trips where I've worked ER for 25 years and I know exactly how it works. But when I got to the ER, the first thing I was told was, I take no medicines all my life. The first thing I was told was, you are drug seeking. First thing I was told, I'm drug seeking. So, and I take no medicines, but I'm drug seeking. So those kinds of things are invariably going to happen, and is based on preconceived notions. It's amazing. It really is amazing. You would think that that doesn't exist in today's world. One last anecdote, and I'll promise I'll stop talking. I was driving to New Orleans and to see a niece who has hydrocephalus and COVID-related brain injury and required decompression. So I'm driving to see her, and I have another niece who calls me. She's in school and says that one of her classmates in medical school said, well, I don't know why you would need anything for pain if you have COVID, especially if you're African American, because we know African Americans don't experience pain in the same way. And this is in medical school that you're hearing this from a colleague. So Kristen, those notions that we're in a current era where that thought process is waning is not true. It is still prevalent because the majority of the people that run the system harbor those same ideas. It hasn't changed. So you have to have a plan when you go into the medical areas and medical fields to seek help. You have to have a plan on how you might need to escalate. And I love the fact that you said, Ms. Fleming, that sometimes you have to ask to see somebody else, and it's okay.
Yeah,
You won't be at fault.
it's
It's
okay.
okay.
And I also think it's important to have an advocate as well, so that if you can't advocate for yourself, you have a family member or a trusted friend. And I can attest today that I'm sitting here in front of you because my husband advocated for me at the hospital. So thank you all for offering that. I know we have a lot of questions in the chat that we still want to get to. So Dr. Davis, if you want to maybe ask the last question that we have for the panelists, and then we could address some more of the questions that are in the chat.
Okay, well, it won't be the last question, but I want at some point to conclude on a positive note about your feelings about, will we get back to something like normal? When do you think that might happen? What would that look like, a new normal, if you want? I hope that can be couched in positive terms. Could each of you speak to that at least briefly?
So I say that we're going to, for me, I'm looking forward when we get to our new way of life, because I don't know that normal as we knew it before 2020 is going to be. From even looking at people working from home, how long are we going to wear masks? How long do we have to socially distance? I mean, you know what I like to do? I like to be able to go to a restaurant and be able to have a meal and not worry about if I'm going to, catch COVID just because I came out and had a meal. And so when do I think, I will tell you, for me, I believe it depends on what percentage of people get the vaccine. I really do. That will determine how long it will take for us to be able to maybe meet up. I don't know, congregate. I don't know when we're going to be able to do that. We still have a huge percentage of people who say they're not going to take the vaccine. And we're still going to have to socially distance and wear masks. And we as a people are struggling with that right now. I think we've kind of gotten used to the mask wearing, but not so much the social distancing. And then when our messaging changes because we have changes with the virus, now we've got these variants. and they're saying, well, maybe we're gonna double mask. And so you got a surgical mask on, you got a cloth mask. You need at least 2 layers of mask. I get everybody's getting weary of it, but since the science changing, the messaging is changing. But I do believe that it'll be midsummer before we'll start to see these numbers kind of level off, and we'll be able to wear masks and walk around and not be as uptight about our environment, I think, as we are today. That's me.
Just to piggyback off of Ms. Fleming, I feel like this is our new norm for a while. Like she said, depends on how many people agree to be vaccinated so that we can kind of flatten the curve. We have a long ways to go. I mean, we are making steps, slow steps. It's a process, it's a journey. And then I think today with the news of the rodeo being canceled this year is a good indication that we are not going to be able to gather in large groups like we knew before for a while. And so in my mind, I'm thinking that this is the beginning to the end of the worst part of it, but we still have a long ways to go. Like, this is our new norm, and we can definitely get through it if everyone's still social distance, wash their hands, wear their masks, like she says with the new CDC guidelines, wearing 2 masks, double masking, and getting vaccinated. We can get through this sooner, but to just kind of adjust to our new norm until we can overcome where we are right now.
Okay, I want to be able to get to some of these questions in the chat. So I will ask that maybe one panelist will address the questions that I'm getting ready to ask just for the sake of time. So the first question is, if we concede that minority communities should receive vaccinations alongside other high-risk communities, what is the benefit to the majority community to this strategy?
Can you repeat that question again? That's a long question. I've missed those points. I have to write this down.
Sure. If we can see that minority communities should receive vaccinations alongside other high-risk communities, what is the benefit to the majority community to this strategy?
Well, if you look at just the benefit to the community itself, right? So if the community that's so adversely affected is lifted from those burdens, then that community's ability to function and perform is increased or goes back to normal. Everyone benefits when there's less disease burden. Everyone benefits when there's less cost that goes out to take care of issues that might be indirectly related, loss of work, people missing jobs, trash not being picked up. The sacrifices that the frontliners, people on the front line are making, will be a lot less. So there'll be less toll on those out there serving as well. So there's a lot of benefit to those, to everyone in the community, if we're safer and there's less disease to go around.
Thank you. So the next question is not necessarily, well, I'll let you all decide, and I'll see which panelist wants to jump in. And Dr. Davis, this might be one. You're the history professor, so you may want to chime in on this as well. But this particular student said this is not so much a race question, but a Texas question. Why does it seem like Texas and the leadership in Austin is more concerned about capitalism over human life? Dr. Davis, I feel like you want to take a stab at this.
Well, it's like Dr. Evans said earlier, how long do you have? I mean, that's such a fundamental question. This is a culture that I teach Texas history. It's a very conservative culture. And one of the ways you measure that is there's a lot of emphasis upon property rights. And so when I hear about, well, we need to get back to normal and open up the economy fully and the like, I understand that a lot of small businesses are really hurting. There's a club that my wife and I love to go to and hear live music, and I'm sure they're barely hanging on in a lot of our favorite restaurants and the like. But ultimately, you can't put property over lives. You know, when Jefferson wrote in the Declaration of Independence, he didn't talk about life, liberty, and property. He talked about life, liberty, and the pursuit of happiness. And I think life is fundamentally the most important. And our politicians in Austin, and let's be blunt, it's Republicans who dominate the state. They've dominated the state for the last 25 years. They have a very conservative philosophy about property rights and about individual rights and this kind of thing. And I think that's at the root of a lot of the problems we face. I've told people a lot, I try to stay at home because I can't go anywhere without running into people who are not wearing masks. And it sends my blood pressure soaring because it's putting all of us at risk. It's putting my 85-year-old mother at risk when I'm exposed and maybe could pass that on. And I think it's just pervasive, especially here in Texas. And, you know, again, it's a product of our history. So that's my take on it.
We have one more question that I want to ask, and then I'll ask each panelist to kind of give their final thoughts. So this question is for you, Dr. Williams. Do you think that young adult African Americans are taking the virus seriously? I see this as a problem in our community. How can we help bring awareness to young adults?
Well, to answer your question, I have a mixed group of individuals that come to me that range from various ages. Some err more on the side of, if I would say, more of a conspiracy theory where they don't believe in the vaccine. They don't feel like this is the cure for what is going on in the pandemic, and they just are opting not to be vaccinated. They are not interested in it. They follow the CDC guidelines to a minimal, and with that, I say they are still going to outings and social events. I can't say that they always wear their mask like they should and social distance. But then there's another group, age group that I speak with, and they believe in it heavily. So they've been exposed to it. They've had family members to die from it. They've had direct impact on it. And I think the more that it hits home, the more people are more likely to understand the importance of either being vaccinated or just following the basic CDC guidelines. Wash your hands, social distance, wear your mask, because you're not only putting yourself at risk, but other family members at risk as well. And I think when it hits close to home, it's when the younger population is more like, okay, my grandmother or my sister or my mother was hospitalized due to this, then they take it a little bit more serious. So I think it's more of seeing it firsthand versus reading about it or seeing it on the news, but being affected within their own home and in their own family is when they take it a little bit more seriously.
Absolutely. So before we wrap up, I just want to give each panelist, if you have some parting words, if you have some words of encouragement for our students and maybe how they can help, you know, make sure that we're practicing good safety and hygiene and, you know, talking with their family members. You know, I have family members who are above that 65 and who are still saying, I'm not getting the vaccine, and they're super high risk. So what would you say to college students? What type of conversations should they be having with their friends and their family members?
Know the science. As a college student, you're studying and you're learning. Make sure when you're having conversations with your friends and your relatives, you're talking to them about the science in a language that they understand. All right. Why is the vaccine important? For those family members that are over 55, 92% of the people in this country who have died of COVID are over 55. But for the young folks, don't think that doesn't mean that it couldn't happen to you, because we also see younger people that die from this as well. I say know the science, be able to have a conversation where you know from the science what is going on, the aspects of this virus, why the vaccine is important. Ask them why. So often, too many times, we want to tell people, well, you need to do this. But why do they need to do it? We've got the high death rate. Well, I'm afraid of it. Well, tell me what it is about it that you're afraid of. Like somebody said earlier, it's not live virus. All right. It boosts your immune system. The side effects, not everybody gets side effects from the vaccine. I have a 67-year-old employee who's had both of her shots and she had no side effects. So just because your neighbor had a headache and have fatigue for days doesn't mean it's going to happen to you. But to have COVID is a lot worse than 2 or 3 days of side effects. And so, young people, know your science when you're having a conversation. This is the time for you to be the bellwether, as I used to tell my daughter when she was, growing up. Set the pace. You be the example. Just because your cronies don't wear their masks don't mean that you shouldn't wear your mask. Wear your mask and socially distance. And then stand up for what you believe in. If you believe in masking up, being distant, and the vaccine, stand for that. I will leave my parting words is that if you can get the vaccine tomorrow, get it. All right? Because unfortunately, I don't think COVID is going away or even going to start to decline until we get more people vaccinated. Thank you for having me tonight. I've enjoyed this discussion.
Yeah. So just a few parting thoughts. I understand that fatigue is real. The mental fatigue, the physical fatigue. These are real events, and this is really happening. But just try to hang in there. And it's for the students, and don't give up in a short period of time, because when you look back at this experience, you'll realize that it probably didn't take as long as some other things that you thought would take. So, and you'll look at it from a totally different light because you'll be beyond this point. So stay vigilant, stay strong. And the encouraging part that we all should be getting excited about is that the technology shift is tremendous from the medical standpoint. You have to remember, Texas had to be sued just to let telemedicine happen, right? Had to be sued by several different entities just to let every other state in the country was going. Texas had to be sued 4 or 5 times. So just think, we've gotten this technology boost, how great it's going to be able to utilize this, that we've made a giant leap into the future. And some of the things that we want to do now or wanted to do in the past, we don't want to do those things anymore because we'll be in a better and different position. So just be excited. Get involved with the technology of medicine. Get involved and learn how you can utilize this change to propel you forward to even greater heights than you had thought before. So be encouraged. Don't grow weary in well-doing. Don't get fatigued. Just keep moving forward. It'll all pay off in the end.
Yes, I agree. COVID-related stress and anxiety is real. We have been thrown a lot of curveballs within the last year. So I'm encouraging students to find a healthy, socially distanced hobby, whether it's going for a walk, exercising. If you need to see a therapist to work through any related COVID stress or anxiety that you need to help deal with the pandemic, I encourage it, because your mental health is definitely just as important as your physical health. And like everyone on the panel said, this is a journey. So we're in it for the long haul. So in order not to get fatigued, you have to preserve your mind and your body. So exercising, seeking a therapist. But if you can get the vaccine and know that it is going to get better. I'm hopeful that it's going to get better. I know it's going to get better. We have to believe it's going to get better as well, but we also have to do our part. So if you can do your part, whether that's wearing your mask, washing your hands, and socially distancing, it can definitely help. Thank you for having me, Kristen and Dr. Evans.
Well, let me just tell you, my email is blowing up, the chat is blowing up. The audience has truly enjoyed this conversation and panel. I mean, people are saying this is the best event they've attended this year. Someone said that they learned a lot. Their sister is a medical doctor, but she went back to get an MBA in health equity. And this student said he understands why she did. And so it's great. This is what we're here for. We're here to enlighten people and to inform them. I do want to answer one question. It says, where can students go for mental health assistance? So Dr. Williams, thank you for bringing that up. We do have a community and schools counselor on campus. I can put her information in the chat. I'll put her email, but she is someone that can do counseling in-house, but also if you need to be referred to an outside agency, she has that information as well. So I will put that. You can also talk to any of our other division counselors as well, and they can refer you to. So this has been an amazing panel. Thank you all so much. Thank you for saying yes to me. We truly appreciate it. We have some great events left for the rest of the month, and so I'll hope that you all will tune in and join us for those events. Dr. Davis, if you have any last words, please jump in.
Well, I just want to say thank you so much. It was a great discussion, and what a wonderful beginning to Black History Month. And I know a lot of my students are going to watch the recording of this, and they'll get so much out of it. So thanks to everybody on the panel and Kristen for putting that together. Thank you.
No problem. If anyone wants to hang back, I'm going to put that email in really quickly, and then you all can log in. So thank you again to our panelists. We really appreciate you joining us.